Hello, our dear students. We continue our distant lectures with you. The topic of today's lecture is age-related dosage forms. Age-related dosage forms include two groups, children's dosage forms and geriatric dosage forms. Since the topic is large, in this lecture we will consider children's dosage forms and in the next geriatric. Let me remind you, I am Afsana Məmmədova, PhD by Pharmacy, Assistant Azerbaijan Medical University. If you have any questions about this lecture, you can contact me at the email address indicated on the title page. Let me introduce you to the short plan of our lecture. We will try to cover the following topics with you: definition of dosage forms for children, features of the child's body in pediatric practice, requirements for these dosage forms, their characterization, their composition and technology, liquid dosage forms, rectal, soft, solid dosage forms for children, standardization of these dosage forms, rule for dosing medicines for children, and modern problems of technology of children's dosage forms. Dosage forms for children include medicine in the appropriate age dosage with a correct taste, the necessary effectiveness of the action, and convenient packaging for use. So children's medicines allowed for use in pediatric practice in the relevant age child doses, the dosage forms that provide therapeutic benefits and convenience of currently. The manufacture of dosage forms for children in developed countries is carried out by dozens of firms, and their nomenclature is in the pharmaceutical practice of individual states reached hundreds of names. Leading places for the production of dosage forms for children in the world are France. Nearly 55 companies produce 102 drugs. The USA, England, Germany. France has a specialized department producing medicines for babies. The problem of creating dosage forms for children put forward by the World Health Organization is relevant and timely, since the peculiarities of the physiological and biochemical processes of the child's body indicate that a half dose of medicine intended for an adult cannot be adequate for a child. Thus, it is unacceptable to recommend taking teaspoons or 1/4 tablet for children. So, definition of dosage forms for children. Children's dosage forms are a specific group of drugs that require special conditions of preparation, the strictest observance of asepsis, operational discipline, full responsibility for the preparation, quality control, and design to dispense drugs. The psychological, anatomical, and physiological biochemical characteristics of newborns and infants require a qualitatively and inappropriate approach to the technology of dosage forms. The reaction of a developing organism to various stimuli that differ from the reactions of an adult. Exchange processes are only established in the first 3 months of life. Let's see how we classify children by age. Preemie. This period covers 37 weeks gestation. Gestational age is the time from conception until birth. Full term. This period from 37 to 42 weeks gestation. Neonate, which cover first 30 days of life. Infant, first year of life. Toddler, from 1 to 2 years of life, child when age from 3 to 11, and adolescent age 12 on, commonly from 12 to 16. A newborn makes from 40 to 60 respiratory movements per minute, an adult 15-18. The pulse in a newborn is 140, in an adult from 70 to 80. The full blood circulation in a newborn is 12 seconds, and in an adult 22 seconds. Pharmacokinetics in children of different age groups has features at various stages: absorption, distribution, metabolism, excretion. Knowledge of the pharmacokinetics properties of drugs in children will improve the effectiveness and safety of drug therapy. Let me briefly consider the moments of pharmacokinetics at different stages. Pharmacokinetics started from absorption, which include oral administration, intramuscular administration, and percutaneous or transdermal absorption. Distribution, which include protein binding, blood-brain barrier, hepatic metabolism, and last of course excretion, which include renal excretion or elimination from skin. Pharmacokinetic differences in newborns and infants affect drug selection and dosing. Therefore, an understanding of basic pharmacokinetics in the pediatric population is essential for positive therapeutic outcomes. Pharmacists' awareness of the characteristics expressed in pediatric patients is crucial, as these distinctions affect bioavailability, serum concentrations, and ultimately therapeutic or toxic outcomes. This punctuates a need for basic understanding of pediatric pharmacokinetics and careful selection of drug, dose, and form. Pediatric patients differ in terms of gastric pH, gastric emptying time, intestinal motility, and gastric enzymes. With the exception of a low gastric pH during the first 24 to 48 hours after birth, neonates have near neutral pH in their first 1 to 2 weeks of life. As gastric acid production begins, gastric pH slowly declines until about age 2, when it approaches adult levels of 1 to 3.1. Weakly acidic drugs like phenytoin, phenobarbital, and acetaminophen are best absorbed in their non-ionized form. In neonate or infants' alkaline gastric environment, these drug molecules generally remain unprotonated, decreasing absorption and subsequent therapeutic effect. The opposite holds true for weakly basic drugs like ampicillin and naphthalene. They are less ionized and better absorbed. Gastric emptying time is significantly slower in neonates and infants until about 6 months of age. It can vary due to both gestational age and disease states. Lowered motility and peristalsis in neonates and infants lead to decreased medication transit time. The long amount of time that drugs spent in the stomach of a newborn further reinforces the increased absorption of penicillins. Motility patterns are variable across not only pediatric age groups but also individual newborns. These patterns also depend on gestational age and affect the rate and extent of absorption. Lowered intestinal surface area and transit times allows for less absorption. The skin of a newborn baby has a high absorption capacity. As a result, a certain danger arose for the body of a newborn, the protective reaction of which is much lower than that of an adult. All this indicates the need for a responsible approach to the use of medicines for newborns and children 1 year old. In infants, the ratio between the volume of extracellular fluid and body weight is different than in adults. The water content in the baby's body is 74.7%, the adult 58.5%. The daily exchange of extracellular fluid 5.6 and 14% respectively. Distribution is dependent on the drug's chemical properties and the body's composition. At birth, a neonate is about 80% water. Water-soluble drugs dosing in a neonate requires a higher milligram to kilogram amount for comparable plasma concentration. That goes for drugs like morphine, gentamicin, and vancomycin. In newborns, the permeability of a number of drugs through the blood-brain barrier is noted. The newborn's liver extracts less medicine from the bloodstream and to a lesser extent retains them in its cells. The lack of enzymes and hormonal systems in a child affects the biotransformation of drugs. There is a decrease in the degree of binding of drug substances to plasma proteins, which leads to an increase in the concentration in the blood, organs, and tissues. Neonates have decreased activity of many enzyme pathways, that is why drug dosages are decreased for neonates. Understanding the features of pharmacokinetics allows to optimize pharmacotherapy for each newborn or child up to 1 year and not limited to a mechanical recount of doses depending on age. Due to illegal education, a child's body is very sensitive for macroorganisms. Microbial contamination of dosage forms makes them dangerous for the body in relation to the development of infection. Often there are pyrogenic reactions of the body in response to the introduction of drugs contaminated with microorganisms. The structural features of the child's body contribute to the rapid release of the drug substance into the extracellular fluid and its rapid elimination from it. Children have different levels of absorption, metabolism, and excretion of drugs. The release of drugs is much slower due to imperfection of glomerular filtration and tubular secretion in the kidneys. Therefore, in the treatment of a sick newborn, the difference between low, ineffective, and toxic doses is negligible. And so, from the foregoing, we come to the following conclusions. As a consequence of organ immaturity, newborns and babies in the first year of life have very different pharmacokinetics from adults. Fewer albumin proteins, so greater concentrations of free drug. Elevated free drug levels, so more intense response. Decreased hepatic metabolism, so prolonged response. Decreased renal elimination, so prolonged response. And blood-brain barrier not well formed, result increased CNS effects. Babies under the age of 1 year are more sensitive to drugs. Immaturity of organs puts neonates infants at a risk for more intense, more prolonged response, increased risk of adverse effects due to kinetics, age-related unique adverse effects, for example, kernicterus. At the age of 1 year, most pharmacokinetic parameters in children are similar to those of adults. Requirements for children's medical forms. At first, it is high efficiency and high therapeutic viability. They must be sterile, commonly for newborns, stability, no pyrogenic for babies, lack of allergic, no toxic, microbiological purity, ease of use, pleasant organoleptic properties such as color, taste, effect, smell, should provide a positive psychological, physiological effect on a child, kind of dosage form, color, taste, effect, smell. It is advisable not to use injections. The technology is aimed at obtaining medicines, the prescription of which will make the child's psyche available. Researchers are developing special oral dosage forms with improved taste, as well as dosage forms that can replace injections. Liquid, rectal, encapsulated dosage forms also have this quality. The dosage form for children is selected taking into account the age of the child. Most drugs are designed for oral administration. For preschool children, liquid forms are recommended, such as syrups, solutions, suspensions, emulsions, elixirs, rinses, soluble tablets, granules for subsequent dissolution, drops. For school children, in addition to dosage forms, tablets, drages, capsules, granules, rectal dosage forms in appropriate age dosages are also being developed. In order for children not to be 3 year old, there was no need for the release of medicines, especially tasty and brightly colored, attractive looking, reminiscent of the confectionery. All dosage forms for newborns and children of the first year of life are sterile. The limits of the quantitative content of microorganisms set by NTD, normative technique documents. They have their own special properties and forms in which identical form of biologically active substances are present. When creating dosage forms for children, only harmless excipients, active natural products are used. Their number should be justified. For coloring, natural dyes that are harmless in medical practice should be used. Corrective substances should give the medicine a pleasant taste and smell. However, there should be less chemicals. The volume of fluid required medications should not be too large, 2.5 to 10 milli. It is also necessary to create dosage forms for children of prolonged action. In case of incompatibility or unsatisfactory compatibility of the ingredients, so-called mixed packages are created. Medicinal substances are stored immediately before use. In addition, there are concentrate, powders, and granules. For accurate dosing of drugs, special dosing devices such as dispensing spoons, beakers, droppers, pipettes, etc. should be used. The package with the medicine should only be in an adult. For solutions in which potent substances are used, when developing tablets and drawing for children, one should strive for the smallest size, from 3 to 4 millimeter and below, and be convex form. Currently, it is necessary to develop rectal dosage forms for children, such as suppositories, microclysters, aerosols, rectally, capsules, ointments, etc. Drugs for newborns. At first, they must be sterile. Commonly, these are solutions for internal and external use, eye drops, oils, and injectable dosage forms, and which are requirements for medicines for children under 1 year of life. They may contain no more than 50 bacteria and fungi in the absence of Escherichia coli and Pseudomonas aeruginosa and Staphylococcus aureus. Which factors we must consider when creating dosage forms for children? At first, only harmless excipients must be used, mainly natural products. Their number should be reasonable to ensure the optimal therapeutic effect and stability of the drug. For coloring, natural dyes that are harmless in medical practice should be used. Flavoring agents should give the medicine a pleasant taste, smell, and color, mix well with the medicine, not reduce its activity, stability, be indifferent or useful to the body substances, be stable in a certain pH range, resistant to light, oxidation, and recovery. In case of incompatibility or unsatisfactory compatibility of the ingredient, the so-called mixed packages are created. Medicinal substances are stored in it separately from the corrigant solution, and they are mixed immediately before use. In addition, concentrates are created, powders and granules, to which water is added before use. For accurate dosing of drugs, special dosing devices such as dispensing spoons, beakers, droppers, pipettes, etc. should be used. The medicine package must be with a protective device that allows to be opened only by an adult. For solution containing potent substances, it is recommended to add the drops supplied in the package with a special measuring device. When developing tablets and droges for children, one should strive for the smallest size from 3 to 4 mm in diameter and below, and biconvex shape. And we must consider the long time of action. They must be children's dosage form must be prolonged action. What are the sanitary requirements for the children's dosage forms? Manufacturing drugs under aseptic conditions. In aseptic boxing, eye drops, children's dosage forms, and intrapharmacy blank are made. Medicinal substances necessary for the preparation of medicines under aseptic conditions and stored in barrels in tightly closed cabinets. Barrels are washed and sterilized before each filling. Auxiliary material is prepared, sterilized, and stored in closed bottoms for no more than 3 days. Auxiliary material and closures used in the manufacture and packaging of medicines are prepared. Currently, any drug substance does not enter the body in its pure forms. It has a dosage form appropriate for its purpose, which is a kind of composition of the active substance and one, but more often several auxiliary materials. Excipients not only help to give the drug the right dosage form, a set of necessary physico-chemical properties for proper distribution through the body, but can also potentiate the effect of the main active substance of the drug or smooth out its side effects. That is why the choice of excipients must be approached with particular care. In other words, the excipient should not be used at all, but specifically with an individual drug. Unreasonable use of excipients can lead to a decrease, distortion, complete loss of the therapeutic effect of the drug substance. This occurs mainly due to the interaction of medicinal and auxiliary substances in the manufacture of drugs in the dosage form itself, or more often after its appointment to the patient. Such interactions are mainly based on the phenomena of complexation and adsorption, which can drastically change the rate and completeness of absorption of active substances. In the course of many years of research, the requirements for excipients were determined. At first, they must be chemically indifferent. It means be chemically or physico-chemically compatible with medicinal substances, packaging, and closures, as well as with materials or technological equipment during the preparation of medicines and during their storage. Comply with the medical prescription of the drug. It means ensure the manifestation of the proper pharmacological action of the drug, taking into account its pharmacokinetics. They must be biologically harmless and biocompatible with body tissues, not have allergenic and toxic effects. They must give the dosage form the required properties, structural, mechanical, physico-chemical, and therefore ensure bioavailability. Excipients should not adversely affect the organoleptic properties of drugs, such as taste, smell, color, etc. They must correspond to the degree of microbiological purity of the manufactured product according to the requirements of the maximum allowable microbial contamination. Be able to undergo sterilization, since excipients are sometimes the main source of microbial contaminations of drugs. And of course, they must be affordable and relatively cheap. The development of pediatric medicines can be challenging since this is the diverse patient population with specific needs. For example, the toxicity of excipients may differ in children compared to adults, and children have different taste preferences. Acceptable palatability of oral pediatric medicinal products is of great importance to facilitate patient adherence. This has been recognized by regulatory authorities and so is becoming a key aspect of pediatric pharmaceutical development studies. Many active pharmaceutical ingredients have adverse taste characteristics, and so it is necessary to utilize taste masking techniques to improve the palatability of pediatric oral formulations. The pediatric population represents a diverse group of patients exhibiting differences in biological and physiological attributes compared to adults. Indeed, children are not merely miniature adults because sensory systems mature postnatally and their responses to certain tastes differ markedly from adults. Amongst these differences are heightened preference for sweet tasting and greater rejection of bitter tasting foods. In addition, active pharmaceutical ingredients and excipients are metabolized differently by children of different age compared to adults. Therefore, the use of certain excipients may not be appropriate or the levels will be restricted, which feature complicates excipient selection. Indeed, when designing an age-appropriate pediatric medicinal product, the excipients used should be selected using a benefit-risk approach encompassing all aspects of the proposed excipients in parallel, including physicochemical properties such as stability, solubility, compatibility, etc., purity, identification and quantification of impurities, toxicity, it means quality and relevance of data, acceptable daily intake, tolerability, risk of allergies, sensitization, karyogenicity, gastrointestinal, osmotic effects, and metabolic fate, caloric contribution, the patient's age, the patient's susceptibility, such as diabetic patients, patients with allergies, etc. Dosage regimen, exposure, quantities, duration, and frequency of administration. Possible cumulative effect with excipients in concomitant medication, and regulatory status. Depending on the effect of the physicochemical characteristics and pharmacokinetics of the dosage forms, they are distinguished so: stabilizing, solubilizing, form-forming, prolonging, corrective, and emulsifying. Natural excipients have an advantage over synthetic ones due to their non-toxicity. Therefore, of all the auxiliary substances, most of them are of natural origin. However, they have a microbial contamination, therefore dosage forms, especially solutions, are very prone to quality loss. In addition, not only opportunistic but also pathogenic microorganisms can be found in the microflora. In this case, the use of acceptable methods of sterilization, the addition of antimicrobial substances such as preservatives, can lead to a reduction to the maximum permissible norms of microbial contamination of natural auxiliary substances. Currently, natural excipients are used as excipients, fillers, binders, prolongators, flavoring agents, etc. For medicines in small quantities, for each dosage form there are certain excipients. For the production of powders, lactose, sugar, or starch is most often used. Cocoa butter, paraffin, wax are introduced into the compositions of the suppositories. Injection solutions also contain their formers purified water, alcohol, polyethylene glycol. Excipients such as gelatin and cellulose ethers are present in capsule manufacturing technology. Stabilizing substances, substances that have natural properties that protect drugs from harmful substances resulting from chemical or microbiological effects. There is a division of stabilizers depending on their actions. First, substances that stabilize the physico-chemical properties of drugs, for example, equal or viscose dosage forms, gelatose, methylcellulose, sodium methylcellulose or CMC, PVP, polyvinyl pyrrolidone, aerosol, twin AT. Second group, substances that stabilize the microbiological properties of drugs, antiseptics and preservatives. There are sorbic acid and gasoline acid used in oral and external dosage forms, sodium metabisulfate and benzyl alcohol as an auxiliary substances in injections. Third groups, substances that stabilize the chemical properties of drugs. These include pH stabilizers such as citric acid, sodium bicarbonate, borate phosphate buffer system, antioxidants, sodium sulfite, unitiol, ascorbic acid, tocopherol, and anti-catalyzed complexing agents such as trilone B or EDTA. Solubilizers. Solubilizers are substances that increase the solubility or difficulty soluble or insoluble active substances in a dosage form. In this regard, solubilizing substances are more often used for the manufacture of solutions for external, internal, and injection administration. The properties of this group of excipients allows the preparation of drugs which particularly insoluble, highly effective drugs such as ichthyol solution, hormone solutions, etc. As solubilizer, twin AT, Ritinox AT, PP4T are most often used. Prolonging substances. There are auxiliary substances that increase the residence times of drugs in the body. They provide an increase in the duration of action of drugs, reducing the rate of release of the active substances from the dosage forms, depositing the drug in organs and tissues, or preventing the inactivation of the active substances by enzymes and the rate of its excretion from the body. Prolongers include methylcellulose and CMC, 1%, polyacrylamide from 0.5 to 1%, polyvinyl pyrrolidone, collagen, and IUDC. Emulsifiers are substances that give stability to emulsions. Distributed at the interface, this group of excipients prevents coalescence. Depending on the type of emulsion, direct and reverse, there are also emulsifiers corresponding to them. For direct emulsions of the oil in water type, sodium lauryl sulfate, gelatin, dextrin, large molecular weight colloids, etc. are used. And for inverse emulsions of the water in oil type, phospholipids, resins, wax, aerosol, clay, bentonides, etc. are used. Taste perceptions of children, especially in the first year of life, are distinguished by a certain orientation, such as bitter, unpleasant tastes, cause negative emotions in children. So receiving, choosing, prescribing medicines in childhood are very responsible, often decisive moments of successful pharmacotherapy. Corrigens include auxiliary substances that can correct the taste, color, smell of various medicinal substances, which is of great importance in children's practice. Natural and synthetic substances, usually in the form of solutions, syrups, extracts, essences, are currently proposed for use as corrigens. Of the syrups, sugar, cherry, raspberry, licorice are especially common. Of the sweeteners, sucrose, fructose, sorbitol, saccharin. The most promising is sorbitol, a sucrose substitute. Forming viscose solutions, it also stabilizes many medicinal substances. Various IUDs are also used whose macromolecules envelop the molecules of drug substances and the taste buds of the tongue. These include agar, alginate, MC, it means methylcellulose, pectins. Essential oils are also have a corrective effect, such as peppermint, anise, and orange. Color flavoring agents include substances such as indigo carmine, acid retrosi, tropiolin, OO, tartrazine, eozyne, etc. It should be noted that it presents the need for special children's dosage forms that take into account the psychophysical characteristics of the child's body as much as possible is recognized by most researchers. As dyes in children's dosage forms are used, carotenoids, chlorophyll, indigo carmine, tropiolin, ruberosum, etc. Now briefly consider some of the ingredients that are often used in the manufacture of children's dosage forms. Fatty oils, olea pingua. Fatty oils are mixtures of glycerides of various high molecular weight fatty acids. Fatty oils are obtained by pressing from seeds and fruits. For the preparation of injection solutions, oils obtained by cold pressing from fresh seeds are used. In fatty oils used for the preparation of injection solutions, such as almonds and peaches, the syrup content must be determined. Determination method presented in the slide. Packaging in children's dosage forms should be well designed so as not to cause negative emotions in children. If necessary, there should be a dispensing tool, such as measuring spoon, glass, pipette, dropper, etc. Current use of medicines for the pediatric population reflects the full range of dosage forms and routes of administration used for adult medicines. Common routes of administration in pediatric patients include oral, parenteral, dermal, pulmonary, nasal, rectal, and ocular uses. In this slide, you see all routes of drug delivery. Now, let's see what dosage forms are used for children. These are oral dosage forms, rectal dosage forms for the treatment of skin diseases, or transdermal dosage forms, eye drops, nasal drops, injectable forms, inhalation dosage forms, which are commonly used in pediatric practice. Here is a more colorful presentation of the above. In this slide, you see a schematic representation of the above. This slide schematically shows the relationship between the route of administration and the dosage form. So, per us orally using tablets, capsules, syrups, suspensions, or topically used ointments, creams, gels, pastes. For ophthalmic use, we use such forms as eye drops, ophthalmic ointments, and gels. Parenterally using intramuscular injection, intravenous injection, subcutaneous forms, inhalation using aerosols, nebulizers. Rectal forms are suppositories, enemas, vaginal forms, pessaries, etc. The oral route is the most preferred and most appropriate route of administration to pediatric patients. It is generally acceptable in all age groups if administered in a suitable dosage form, for example, in liquid form for the youngest age groups which have difficulties in swallowing solid dosage forms. Strictly, the choice of oral administration depends on the gut function and thus on both age and clinical condition. Consideration should be given to effect of increased gastric pH and intestinal mobility at birth and early infancy. In addition, gastric emptying of sick newborns is most erratic and can be delayed. Mixing oral dosage forms with food or beverage is not preferred but may be performed to enhance compliance. Potential effects of foods on bioavailability should be considered. When recommending mixing medicines with food, the effect on the taste should be considered, as an unpleasant taste of medicine may cause aversion in children. But in liquid dosage forms, like in no other form, such properties of the drug as taste and smell are manifested, which are often the cause of many complications of pharmacotherapy. Researchers from many countries are now focused on eliminating unpleasant taste and smell, giving the medicine an attractive appearance. One of the specific features of liquid dosage forms for children consists in the creation of drugs with improved taste. Another feature is the selection of solvents and excipients used for the preparation of a liquid dosage form. Currently, liquid dosage forms for children are generally formulated using the same substances as adult dosage forms. At the same time, age-related pharmacology dictates the need for the choice of suspending, emulsifying agents and other excipients, taking into account the specifics of the child's body. Liquid formulations include solutions, syrups, suspensions, and emulsions, and are most appropriate for younger pediatric patients, for example, birth to 8 years, who are unable to swallow capsules or tablets. All types of liquid oral dosage forms, such as solutions, medicines, drops, infusions, decoctions, suspensions, emulsions, are widely used in children's practice. Such popularity is due to the biopharmaceutical aspects related to the uniformity and speed of absorption of drugs, the distribution and excretion, as well as the exclusion of pain when taking the medicine, the accuracy of dosing. Once in the child's intestines, liquid drugs spread over a larger area of the mucosa and are better absorbed by it. Suspensions and medicinal syrups, however, are fraught with considerable danger. Since they are quite tasty, children tend to drink more of them. It happens that a child imperceptibly for parents swallows at one time the entire vial of medicine he likes. Drops containing alcohol are prescribed only for infants. In this form, in addition to herbal tinctures, some expectorants are available. For example, bromhexin. Drops must be diluted in chilled boiled water so that no bitter alcohol taste is felt. This will not interfere with the therapeutic effect. Oral effervescent dosage forms include tablets, granules, and powders that are dissolved in water prior to administration. Effervescent products are alternatives to liquid dosage forms for substances with insufficient stability in aqueous media. They are also more portable than conventional liquid formulations. For substances that are not stable or cannot be taste masked in liquid preparations, powders, or multiparticulate formulations, for example beads, granules, and mini tablets, are encouraged. These can be dosed directly into the mouth of the pediatric patient or by mixing the prescribed dose with a small amount of soft food or with a drink prior to administration. Formulations can be provided in a bottle with dosing scoop or in single-dose sachets. They may also be supplied in the form of capsules, the contents of which can be sprinkled onto food. Orodispersible dosage forms may comprise orodispersible tablets, lyophilized wafers, and thin films, and are placed in the mouth where they disperse or melt on the tongue. Orodispersible dosage forms hold great promise for children as they are easy to administer, do not require additional water, and as long as dispersion is rapid, are difficult to spit out and could provide a range of dosages appropriate for use in younger children. Only a few products are currently authorized for use in the pediatric population and only above the age of 6 years. Different orodispersible dosage forms will differ in their dispersion time, mouthfeel, potential for taste masking, and in the dose which can be formulated. Taste will be a particular challenge as this will be a limited quantity of sweeteners and flavors that may be incorporated into this dosage form. The use of insoluble salt forms and or taste masking technologies such as particle coating may be considered to improve palatability. It should be noted that while these strategies reduce the solution in the mouth and hence taste perception, they might affect the pharmacokinetic profile. Chewable tablets are valuable pediatric dosage forms for children of 2 years and older. They are considered to be safe in younger age groups of administration if administration is supervised to ensure through chewing to reduce the risk of inhalation or ingestion of tablet fragments. Chewable tablets should have a smooth, rapid disintegration. Ideally, the formulation should contain non-cariogenic sweeteners. Among the types of products available as chewable tablets are antacids, antibiotics, anticonvulsants, analgesics, anti-asthmatics, vitamins, and cold allergy preparations. Medical chewing gum has only been used for relatively few pediatric formulations such as dimenhydrinate and fluoride. However, it may be a suitable dosage form for children as most children of age 6 years or older are familiar with chewing gum. Chewing gum is easy to administer, does not require additional water, and may be taken anywhere. It may be possible to mask the unpleasant taste of active substances by sweeteners and flavors added to the chewing gum. The release of the active substances is controlled by various means such as solubilizers, ion exchange, encapsulation, and the amount of gum base. The minimum chewing time needed to ensure complete release of the required dose should be determined. However, as chewing gum is also appreciated by children as a confectionery, care needs to be taken to restrict their access to any medical chewing gum. Solid oral dosage forms such as tablets and capsules can offer advantages of greater stability, accuracy of dosing, and improved portability over liquid formulations. Formulation taste is rarely an issue with film and or sugar coats used to improve palatability. The primary limitation for pediatric use is that solid oral dosage forms can present significant problems for young children and adolescents who have difficulty swallowing. The age at which children can swallow intact tablets or capsules is highly dependent on the individual and the training and support that they receive from healthcare professionals and caregivers. Anecdotal evidence suggests that with support and training, children aged less than 6 years can learn to take solid dosage forms, particularly for chronic therapy and or when faced with unpalatable liquid formulations as an alternative. The size of tablets and capsules should be kept as small as possible. Dosing of multiple mini tablets may be preferred over a single larger dosage form and can allow dosing flexibility. Scoring of tablets to allow accurate breakage into halves or quarters should also be considered. One of the key advantages of solid dosage forms is that they do offer the opportunity for the development of modified release formulations, which is technically more challenging for liquid formulations. With the aim to improve drug delivery for pediatric patients, the development of a mini tablet may prove beneficial. However, there are no strict regulatory guidelines that define mini tablets. Smaller than typical tablets considered as mini tablets. The term micro tablets are sometimes used alternatively to mini tablets with typical tablet diameters between 1 to 5 millimeters. In general, a tablet with a diameter less than 3 millimeters refers to mini tablets. Mini tablets can also be considered oral granules or sprinkles because those are similar in diameter, less equal 2.5 millimeter, and are intended for dosage administration by mixing with soft food or puree. Mini tablets combine the advantages of both solid and liquid formulation as it allows exact and individual dosing according to age, body weight, body area, body titration, and therapeutic demands. One of the forms of mini tablets are pills, in Latin pillule. Pills at dosage form in the form of balls weighing from 0.1 gram to 0.5 gram prepared from a homogeneous plastic mass. Pills weighing more than 0.5 gram are called boluses. Pills should have a regular spherical shape, not changing during storage. The surface of the pills should be dry and smooth. In a cut, the pills should be uniform. From medicines with oxidizing properties such as silver nitrate, potassium permanganate, a mass is prepared with the addition of inorganic auxiliary substances such as kaolin or bentonite. Liquids not miscible with water must be pre-emulsified with liquorice root extract or apricot gum. The pill mass should be a homogeneous plastic mass easily behind the walls of the mortar and pestle. Ready-made pills are sprinkled with lycopodium powder or starch and pills with oxidizing agents white clay. The pills can be coated with sugar or substances protecting the pills from the action of gastric juice. The applicability of oral mucosal dosage forms in the treatment of pediatric patients needs to be evaluated for safety and compliance issues and generally depends on the age of the child. Buccal or sublingual tablets. Buccal tablets are designed to disperse slowly to give a prolonged release effect, whereas those for sublingual use dissolve promptly and provide a rapid pharmacodynamic response. Limitations include the restricted number of successful drug candidates, the restrictive size of the buccal patch and sublingual area, and concern over palatability and local irritation. For reasons of safety and uncertainty about cooperation, this type of product is not suitable for young children. Buccal or sublingual tablets include mucoadhesive preparations, lozenges, chewing gum, liquid preparations, for example, oromucosal drops, sprays. Advantages are taste, and disadvantages the lack of cooperation of children's, difficulties in coordination, risk of choking and aspiration, non-accuracy of dosing. Mucoadhesive preparations are intended to be retained in the oral cavity by adhesion to the mucosal epithelium and may modify systemic drug absorption in the site of application. They may be supplied as mucoadhesive buccal tablets or other solid and semi-solid preparations. These forms might even be suitable for younger children, but further evaluation is required. Lozenges are hard solid dosage forms intended to dissolve or disintegrate in the oral cavity. They are usually designed to administer active substances locally to the mouth and pharynx, but can also contain substances for systemic absorption. They are only likely to be an acceptable dosage form for older children. Chewing gum releases the active substances to saliva during chewing and may be used for both local and systemic treatment. Chewing gum should be chewed for a certain period of time, usually 10-20 minutes, to ensure release of the intended doses, and afterwards the gum residue should be expelled. The dosage form is likely to be acceptable for children of 6 years or older. Liquid preparations, for example, oromucosal drops, sprays, are solutions, emulsions, or suspensions intended for local or systemic effect. They are applied by installation, spraying, or squirting, oral shearing into the oral cavity or into the specific part of the oral cavity. The applicability needs to be assessed on a case-by-case basis. Rectal administration is an important route of administration that can be used for both local, for example, laxative and anti-inflammatory, and systemic effects, for example, antipyretic and anticonvulsive, in all age groups. The route of administration is especially valuable when oral administration is not possible because of the condition of the child and palatability issues. In certain cases, it is possible to obtain immediate systemic effect by rectal administration of solutions. There is, however, limited absorption and bioavailability for many active pharmaceutical ingredients. Erratic absorption due to fecal contents in the rectum may variably delay absorption. Dosage forms for rectal administration and are primarily suppositories, rectal capsules, and rectal liquids such as enemas. Other dosage forms are available, for example, rectal foams provided in pressured containers. When suppositories and rectal capsules are administered to pediatric patients, there is a risk of premature expulsion, especially when the dosage form constituents have an irritating effect. Rectal dosage forms should be used with extreme caution in the premature population, as they can tear very delicate tissues and thus introduce infections. Concordance and compliance of rectal preparations may be lower than for oral dosage forms. There are barriers to rectal administration for both caregiver and patients in some regions and cultures. Generally, the acceptability among children of any age is poor. Suppositories for use in pediatric patients must be tailored to the age or size of the child. Cutting of suppositories into hulls should be avoided unless they are designed to be cut. The majority of suppositories contain APIs as solid particles, which may be unevenly distributed in the suppository base due to the manufacturing technique by molding a molten formulation. However, if it also possible to prepare suppositories which can be cut in small portions, ensuring delivery of appropriate dose. Information on acceptability of cutting suppositories should be provided. When designed to be cut, information on the technique should be provided in the patient leaflet. Two types of suppository bases are available. First one, insoluble in water, for example, hard fat, which melts below body temperature. And the second type, soluble immiscible with water, for example, macrogols, which are dissolved or mixed with the rectal liquid. Both types may be irritating. With suppository melt formulation, special consideration has to be given to storage temperature. Rectal liquids are solutions, suspensions, or emulsions based on water or vegetable oil. Any volume to be administered should be adapted to the size of the child. For systemic therapy, the volume to be administered should be as small as possible to achieve accurate delivery, good absorption, and absence of irritation. Volumes of 1 to 5 ml may be acceptable. The rectal tube should be of a length appropriate to the size of the child and should not cause injury. Use of pre-filled syringes equipped with a rectal tube facilitates individual dosing and may reduce the need for several strengths of the formulation. Formulation of aqueous rectal liquids has the same features as formulation of other aqueous liquids. Use of stabilizing agents, including surfactants and antimicrobial agents. Non-ionic surfactants are preferred because ionic surfactants are frequently irritating to the rectal mucosa. The need for stabilizing agents, in particular antimicrobial agents, may be reduced by the formulation of rectal tablets to be dispersed or dissolved in water immediately before administration. In children's practice, the following are used as the basis: cacao butter, white of salt, type A solid fat, lazopol. These bases do not absorb moisture from the rectal mucosa and do not irritate it. Rational dose delivery of topical, dermatologicals, and transdermal systems in order to achieve balance between efficacy, local, and systemic safety is one of the major demands of formulations for the pediatric population. Clear differentiation between desired and adverse effects of topical and transdermal pharmaceutical forms is necessary. Penetration and permeation characteristics, such as topical versus systemic bioavailability of active substances, are strongly dependent on physiological factors such as skin site and skin condition, as well as the characteristics of the vehicle, pharmaceutical availability. Important morphological and hence permeability differences exist between normal mature skin and that of a neonate, especially the preterm infant. Eye drops. Eye drops must contain a lower concentration of drug substances and not irritate the mucosa. Nasal dosage forms. Advantages and disadvantages of nasal administration. Many medicinal products introduced into the nasal passage are intended for localized effects on the mucous membrane and underlying tissues. Examples are topical decongestants or anti-inflammatory medicinal products used to treat ear rhinitis or allergy-related indications. However, the nasal route provides direct access to the systemic circulation and may be an attractive needle-free alternative to invasive administrations. Nasal administration may lead to unwanted systemic effect, may irritate the mucosa or cause pain, and be ineffective if secretions are abundant. Nasal dosage forms and formulation considerations that the development of locally acting nasal products has to focus on a minimum of drug absorption into the nasal mucosa and a maximum residence time. In contrast to that, systematically acting products require an efficient absorption into the bloodstream. Nasal preparations are liquid, semi-solid, or solid preparations intended for administration to the nasal cavities to obtain a systemic or local effect. Nasal dosage forms include nasal drops, nasal sprays, and nasal powders. Nasal drops are intended for installation into the nasal cavity and usually are supplied in multi-dose containers with a suitable dosing device. On account of insufficient reliability in dosing characteristics, nasal drops are not recommended for administering highly potent or systematically acting drugs. From an anatomical point of view, nasal drops may be preferred for infants since the nasal cavity is so small that 1 or 2 drops can cover the whole mucosa. Nasal sprays are applied to the nasal cavity for local and/or systemic effect. They can be supplied in squeeze bottles, mechanical dispensing systems, or pressurized containers such as nasal aerosols. The applicability of the traditional squeeze bottle is restricted due to its significant dose variability. In contrast to that, the pressurized metered dose systems for nasal administration are very reproducible in dosing and droplet size distribution. A major disadvantage is the puff's strong impact on the nasal mucosa, which results in a local irritation, such as coldness, and additionally restricts the area for drug deposition. Mechanical dispensing systems, which basically consist of a pump with a metering chamber and actuator, are available in great variety and can thus be chosen depending on the technological requirements. For example, two-chamber systems for unstable formulations, and the needs of the patient target group. Actuators for pediatric application are slimmer in their geometry and the dosage volume is reduced. Acceptability and compliance for young children requires future evaluation. Nasal powders are dispensed by means of suitable delivery system. Powder dispensing systems are preferably used for drug substances which are more stable in a dry and solid state, for example, peptides and vaccines. They can be divided into passive and active delivery systems. Active systems are fitted with a mechanism that allows pressure to be built up and eject the powder into the nostril. These systems are especially suitable for children. A variety of drug substances are being evaluated for transnasal delivery to the systemic circulation. Nasal sulfentanyl, midazolam, and esketamine have been used for pre-induction of anesthesia in pediatric patients. The nasal route is also receiving attention for the management of post-operative pain, patient-controlled intranasal analgesia, and with diamorphine for pain relief following trauma. Moreover, the nasal administration of peptides, for example, desmopressin and vaccines, is an attractive route in terms of efficacy and patient acceptance. During product development, the drug properties, the reproducibility and performance characteristics of the device and the nasal anatomy and physiology of the pediatric target group have to be considered. In order to enable the required deposition pattern in the nasal cavity, the delivery system has to be adapted in dose, volume, and dimensions of the nasal actuator. The formulation needs to be as far as possible non-irritating without adversely affecting the functions of the nasal mucosa and its cilia. Penetration enhancers should be shown to be safe and effective in the target population. Parenteral administration by the intravenous route is the preferred route of administration for seriously ill children and for clinically unstable term and preterm neonates in developed world settings. Some parenterals are administered by the subcutaneous and intramuscular routes. The limited muscle mass of newborns and in particular preterms constrains the use of intramuscular injections. Other routes of administration, for example intraosseous, are used in emergency cases. Most children have a fear for injection needles. Possible alternatives especially suited for frequent or long duration of treatment, such as needle-free injection devices, jet injectors, that drive small droplets through the skin by high pressure, could be considered, for example, for subcutaneous administration. However, this is only a limited experience currently available on their use in pediatric populations, especially with smaller children. Aqueous preparations, solutions, suspensions must be adapted to the physiological conditions on the application site. The tolerances for deviations in pH and osmolality are dependent on the route of administration. In particular, subcutaneous administration is highly sensitive because dilution of the injected volume and its escape from the injection site proceeds slowly. Hyperosmolar injections and injections with extreme pH may cause pain and irritate peripheral veins. Formulations for neonatal patients are usually aqueous solutions intended for intravenous administration. Target volumes and electrolyte contents are important for all pediatric patients, however, critical for neonates. It is highly important to consider the safety profile to each excipient and its suitability for the intended use. Consideration could be given to the potential absorption of the active pharmaceutical ingredient on to surface of plastic containers and catheters and leaching of plasticides from containers and catheters to the parenteral preparation. Some APIs are presented as powders or lyophilizates to be reconstituted prior to administration. It is important that clear instructions on the reconstitution and information on storage conditions and time are labeled. Inhalation is a suitable way to administer active substances to the lung. It is the preferred route of administration for patients with asthma. Other diseases such as pulmonary infection in cystic fibrosis can also be treated locally by inhalation. In the future, inhalation might become more important for the application of active substances for systemic treatment. The following statements are mainly concerned with the local therapy of asthma. Recommendation and comments for the selection of appropriate delivery devices in relation to age are available. The use of dosage forms for asthma in children should be in line with the recommendations in the guidelines. However, in young from 0 to 5 years children, little or no evidence is available on which to base recommendations. Advantages of inhalation dosage forms. The inhalation route over the oral route of administration include the avoidance of the hepatic first pass metabolism. Inhalation might be an alternative route to parenteral application for systemic treatment, for example, with peptides and proteins. Compared to the parenteral route, pain during application can be avoided. Disadvantages of these dosage forms that causes mechanical and chemical irritation by aerosol particles of the nasopharynx and can cause a spasm of the larynx. Therefore, it is not recommended to use for children under the age of 5 years. And now let's get acquainted with the features of the technology of dosage forms for children under 1 year old in a pharmacy. The technological process of preparing children's medicine for babies includes the following stages. Preparation of aseptic conditions, preparations of dishes and accessories, preparation of solvents and drugs, dissolution of drugs, quality control solutions, filtering solutions, checking the absence of mechanical inclusions, closing, preparation for sterilization, marking, sterilization, quality control, and design of drugs for dispense. Manufacturing features of individual drugs, such as mixtures and powders. Mixtures are called liquid dosage forms that are obtained by dissolving or mixing in various liquid bases, in water, alcohol, glycerin, vegetable oils, etc. Several solids, or when mixing several liquids, such as solutions, infusions, decoctions, tinctures, extracts, etc. Mixtures contain 3 or more ingredients. Mixtures can be transparent, cloudy, and even with sediment. The latter should be shaken before use. Such portions are called mixture agitande. Mixtures requiring more agitation. Prescribed mixtures most often inside, less often externally. The mixtures are prepared in sterile water or sterilized with a drug solution, and substances that do not withstand sterilization are added under aseptic conditions. Powders for internal use are prepared under aseptic conditions without subsequent sterilization. Powders for external use, such as baby powders, are sterilized by air method. Mixtures are usually prescribed in expanded form. The recipe lists all the ingredients included in the medicine and their quantities, and also writes out in the so-called half-reduced recipe. In such cases, some of the ingredients are given in abbreviated form. It can be solutions, infusions, decoctions, emulsions, mucots, etc. The remaining ingredients are listed in the same way as the expanded version. When prescribing mixtures for internal use, one should proceed from doses of medicinal substances per one dose and the number of doses. Mixtures prepared in accordance with the order instructions for preparation of state pharmacopoeia in pharmacies. Sterilizing at temperature 120 degrees Celsius during 8 minutes. Don't use preservatives and stabilizers. To improve taste and add fruit syrups, lemon acid, not allow packing more than 100 ml for prescription. In this slide, you see a recipe for a mixture that contains sodium benzoate, sodium bicarbonate, and sugar syrup. The technology for preparing mixture is presented in the slide, but I will not dwell on it since this point is discussed in detail in practical lessons. In this slide, you see characterization of above mixture and its theoretical background. In this slide, you see a prescription for a mixture that contains codeine phosphate. There are two forms of prescribing this recipe. The technology for preparing of this mixture is carried out according to general rules. On this slide, you see a powder recipe for a 6-month-old baby that contains aminophylline. At first, as you know and remember, we must check the dose of aminophylline and see if the dose is indicated correctly or not by the doctor. And then, under aseptic conditions, prepare the powder according to general rules. The following is a zinc oxide powder prescription for a 2-month-old baby. Powder under aseptic conditions is prepared according to general rules. Here you see a prescription for a solution of vitamin C, which is also prepared and sterilized under aseptic conditions according to the general rules of technology for children's dosage forms. On this slide you see a prescription for peroxide solution written out for the treatment of the navel of 7-day-old baby, which is also prepared and sterilized under aseptic conditions according to the general rules. Syrups, concentrated aqueous preparations of 85% of sugar or sugar substitutes with or without flavoring agents and medicinal substances. In medical terminology, medicinal syrups are nearly saturated solutions of 85% of sugar in water in which medicinal substances or drugs are dissolved. Types of syrups, there are aromatic or adjuvant syrups, or the alternatively named non-medicated syrups, which include simple syrups, orange syrups, lemon syrups. They are mostly used to improve the taste of salty, bitter, or otherwise unpleasant mixtures. And second type of syrups are medicinal syrups. There are of two types, made from extractive drugs. Here the fluid extract of the respective medicines is mixed with the syrup, and made from chemicals. This can be either by simple solution or by chemical reaction and solution. Here the taste of the medicinal agents is greatly modified, such as paracetamol syrups or piperazine citrate syrups. In this slide you see the recipe for hematin syrup and how to make it. On this slide you see a recipe for iron sulfate syrup and its preparation technology. On this slide you see a piperazine adipate syrup recipe that contains piperazine adipate 5 gram, citric acid 2 gram, sugar syrup 72.5 gram, sodium benzoate 1 decigram, purified water 20 ml. Syrup is prepared according to general rules. This is a clear liquid, slightly yellow in color, sweet and sour taste, odorless, used for anthrabiasis in children. Solutions in liquid dosage form consisting of at least 2 or more components obtained by dissolving a solid, gaseous or liquid drug in a solvent. The most commonly used solvents are purified water, water for injection, distilled water, aqua distillata in Latin, less often ethyl alcohol 17, 90, 95%, in Latin spiritus ethylicus, glycerin, glycerinum, liquid oils such as liquid paraffin, olive, peach oil, adequately in Latin oleum vaselini, oleum olivarum, oleum persicorum, dimethyl sulfoxide, etc. Accordingly, they dilute aqueous, alcoholic, glyceric, and oil solutions, etc. On this slide, you see a recipe for a 2% solution of ascorbic acid, calculations for compiling a work passport, and making technology. The technology for preparing each recipe presented in this lecture is discussed in detail in practical classes. On this slide you see the technology for preparing the presented nitrofural solution. The trade name of nitrofural in Azerbaijan is furacilin. Therefore, in the recipe the drug is indicated as furacilin. This slide shows the technology for preparing a 10% copper sulfate solution. This slide shows the technology for preparing of a 0.2% silver nitrate solution. I want to say that all of these solutions are widely used in pediatric practice. Here you see a prescription written for a 6-month-old baby that contains 0.1% ethacridine lactate as a solution. The making technology is described in detail in the slide. You can familiarize yourself. On this slide you see an ophthalmic solution prescribed for a 10-month-old baby that contains cholargol in an amount of 2%. The making technology is described in detail. In children practice, water extracts are widely used. This slide shows one of them, Datura stramonium, known by the common names stone apple, Jimson weed, or Deval snare, is a plant in the nightshade family. This agent is used in the complex treatment of asthma, cough in children. You see here a detailed description of the technology of this infusion. On this slide you see a mixture recipe that contains valerian root, in Latin rhizomatis and cum radicibus valeriana, grass of motherwort, in Latin Herba leonori, coltsfoot leaves, in Latin Foliorum farfare, viburnum bark, Cortesis viburni in Latin, and prepared according to the classic technology of mixtures. The following mixture that contains valerian, motherwort, analgin, potassium bromide and sodium bromide, and preparing according to the general rules of mixtures. Next dosage form are elixirs. Elixirs are clear, sweetened hydroalcoholic solution. These are intended for oral use and are usually flavored to enhance palatability. Usually less sweet than syrups and less viscous. They are classified into two classes: non-medicated elixirs, there are vehicles, and medicated elixirs used for therapeutic effect. Advantages of elixirs: they are better able to maintain both water-soluble and alcohol-soluble components in solution, has stable characteristics, easily prepared by simple solution, and disadvantages of elixirs that they are less effective than syrups in masking taste of medicated substances and contains alcohol, acanthates, saline tastes of bromides. Alcohol content varies from 5 to 40%, and from 10 to 12% alcohol are stable, not required the preservatives. Method for formulation: simple agitation method used. Alcoholic soluble ingredients dissolved in alcohol. Water-soluble ingredients dissolved in water. The water solution mixed with alcoholic solution. If any oil ingredients added, they use with talc for removing of oil droplets gained filtered. For example, in paracetamol elixir. On this slide you see the composition of the phenobarbital elixir and the technology for its preparation. Quality control of children's dosage forms. In order to standardize children's dosage forms went organoleptic, physicochemical, chemical, biological, microbiological assessment. For all medicinal substances and carbohydrates that are part of children's dosage forms, methods of qualitative and quantitative determination are necessarily developed, and for excipients, mainly methods of qualitative analysis. Features of prescription dosage forms for children. Medications for children are issued on separate forms, prescriptions marked baby, and point the exact age and weight of the child. Taking prescriptions should be checked, and potent doses of toxic substances and the compatibility of registered ingredients to consider the rationality of the combination of antibiotics, sulfonamides, and other drugs. Doses of toxic and strong effective substances in suppositories compare with doses for oral acceptance. When prescribing drugs to children should follow these guidelines. Assign only the intended dose of medicine according to age and body weight. Conduct preliminary test of tolerance and sensitivity to drug intended, perhaps the mother. Consider the functional state of vital organs of the body. Antibiotics and sulfamides are set according to etiology, the properties of microorganisms. Not prescribe those drugs which often cause side effects, desirable after a preliminary test for allergies and sensitivity to appropriate groups A, B, research, and possibly mother. Do not allow amplified drug therapy for benign diseases. Medication use short courses. Do not use both drugs with the same mechanism of action. Carried out taking into account several factors which include pharmacokinetics and pharmacodynamics of drugs, child's age and weight, the nature and severity of disease, state of the liver, kidneys, heart, individual sensitivity of the child, household conditions of life, especially food, climatic and geographical factors, and medical anamnesis. To determine doses of drugs in pediatrics have long used two methods. Empirical, your dose of the drug calculated for children of different age groups based on the effect which was observed from the drug in varying doses. And the method is based on the selection of those doses that are determined by coefficient of special formulas. Empirical, when the dose of medication to reduce children from adult doses according to age. It is not quite accurate as children the same age have different body weight, lodging, meals, etc. According to the method prescribed to children less than 1 year, 1 to 24 and 1 to 12 of the adult dose. From 1 to 2 years, 1 to 12, from 2 to 4 years, 1 to 6, from 4 to 6 years, 1 to 4, from 6 years to 7 years, 1 to 3, from 7 years to 14 years, 1 to 2, and from 14 to 18, 3 to quarter. According to SPU, dose for children can be expected depending on age, taking the dose per unit. All formulas for calculating drug dose are presented in this slide. Drugs which are allowed to take in pediatric practice shall not contain substances that affect the growth of development or development of tissues, lowers immunity, are toxic, do not contain preservatives and dyes. For example, violet tetracycline tools enable in children, affecting the growth of bones. Streptomycin and gentamicin can cause low toxicity. Prohibited medication containing alcohol for children under 1 year. Sulfanilamide elixir death, the tragedy of thalidomide. The sulfanilamide elixir was an improperly prepared sulfanilamide drug that caused mass poisoning in the United States in 1937. He caused the deaths of more than 100 people. The public outcry caused by this incident and other similar disasters led to the adoption of the 1938 Federal Food, Drugs and Cosmetics Act, which led to the creation of the FDA. 25% of the world's population suffered from this medicine. As a result, poorly developed organ functions and a high risk of toxicity and poor clinical response. So, an ideal medicine for children is a medicine that matches the child's age, physiological condition, and body weight and is available in an adaptable dosage form. Thank you for your attention.